Hello and good afternoon, everyone. We at Eventus wish to thank all of you for spending a little bit of your afternoon today on this roundtable that we would like to have your full engagement on. As many of you on this call are aware, we've had some recent survey updates go into effect just earlier this year, and survey updates that really have profound implications for not just the facilities and their quality outcomes and quality metrics, but more importantly, the very patients that we serve. And our hope is that today we can give you some very high-level overview on a specific change to that survey, the survey process specific to FTAG 605. We have had 2 town hall meetings now addressing this very issue. And I am happy to say that those were quite successful in rendering what we felt was an effective solution to the concern of this survey tag at hand. What we really want this to be, however, is more of a bilateral dialogue. We will go ahead and start with just a basic overview, and then we'll dive into some nuances of FTAG 605. I, Sandeep Patel, will also be joined by Dr. Jenny Byrne, the Associate Chief Medical Officer of Behavioral Health, and Monica Leriger, our Vice President of Pharmacy Services, who are also here to chime in and give their perspectives on the specific FTAG and what else we can do to foster solutions together. Sorry, technical difficulties here. As we know, the nursing home space, it's filled with twists and turns and surprises, and this is no different. But then again, many of us on this call have worked together to surmount those twists, turns, and surprises, and I would like this FTAG to be an opportunity that, though it presents a challenge, in challenge lies opportunity, an opportunity to really help synergize efforts and an opportunity to come together to promote solutions for both you all as our facility partners and, of course, the very patients that we serve. So as I alluded to earlier, today we will be going through an overview of FTAG 605. We will then dive into some viewpoints from our amazing pharmacist, Monica Leriger, followed by some viewpoints from Dr. Jenny Byrne, and finally ending with your direct feedback to help really inform further solutions that we can help tailor for you and your needs, at which time we hope we can have a bilateral dialogue with all of you on the call. So just as a broad overview, we know that FTAG 605 has come into being by enveloping the parameters of FTAG 758, unnecessary psychotropic medication. However, bundling it into FTAG 605 brought about new nuances to the tag. It brought about the issue of a concerted look at whether psychotropics, with a focus on psychiatric medications, are indeed being used as potential chemical restraints through with patient effects, as you see here on this screen, and which are of no surprise to us. Furthermore, the transition from F758 and putting those medications under FTAG 605 has brought about a more concrete language surrounding the issues of convenience and discipline. Discipline focusing on using medications to correct an adverse action, such as when a resident goes wandering into another patient's room or resists being given a bath, and we end up giving them out a medication so that they comply. Or convenience, where maybe meds are given so that it takes less nursing effort to respond to a resident's behavioral needs, such as maybe forcing them into a specific sleeping pattern that is not their usual, or restricting their movement from chair to standing position to reduce falls. So both of these have indeed come center stage, and this terminology is important for us to understand, because what we need to do as facilities and as care partners for our patients is really ensure that in our facilities, medications are used appropriately for appropriate indications and not strictly out of the need for convenience or discipline. Furthermore, the FTAG also brings to light and puts front and center, the need for documented proof that non-pharmacological interventions have been attempted and or failed or are contraindicated entirely. And this is where we work together. Our behavioral health team, our primary care team, and you as our facility partners really working to ensure that we've exhausted all possibilities before moving to a pill. And if you notice here, I tagged this as a QAPI moment. hand in hand with these survey updates, the process of QAPI has been a national narrative, the national narrative to improve its meaning, to improve its worth, and thereby improve its ability to truly push care to a new frontier in this industry. I would challenge all of us on this call to really ensure that as a result of FTAG 605 having a concerted lens on non-pharmacological interventions, that we actually make it a discrete attempt that at our QAPI meetings and throughout the QAPI process, that we simply ask the question, are we performing them? Are we documenting them? And if not, why not? And if not, should it be so? So take that moment to do so, because it really does bring the issue to the front of people's minds when they're sitting there in the moment at a meeting. There's also a concerted focus on documentation that an informed consent discussion took place. Did the responsible party, especially if it's not the patient themselves, being able to make the determination for themselves, were they aware of the drug, the indication, the risks, benefits, and any non-pharmacological interventions that were failed or contraindicated? Once again, I'll highlight there, this is a QAPI moment. This is a moment where, when we reflect back on our QAPI process at our facilities and at the QAPI meeting, are we asking the discrete question, are informed consent procedures intact? And are we up to date with ensuring that they're fully documented? Keeping in mind that informed consent is not necessarily an actual piece of paper. The survey guidance has been clear on this. It's not an actual piece of paper you have to fill out, but what does have to be documented is that a discussion that entailed all of the parameters listed did indeed occur. So that's something to keep in mind. If it means that we need to create a system of a formal consent piece of paper, that's great. It protects everything. But even if you don't have a formal consent page or a form to fill out, just simply documenting that the conversation took place with all of these elements is more than enough to suffice for the survey indication. We also need to be sure that all psychiatric medications are attributed to standard diagnostic criteria. And all the more reason why the communication and collaboration we have amongst ourselves between primary care, behavioral health, and of course the facility, nursing, and MDS are tightly knit. We want to be sure that every psychotropic medication, especially psychiatric medication that we use, has a diagnosis attached to it. And if not, really firming up that diagnosis rather quickly, or moving on from that medication and removing it until we find the indication otherwise. I will also say nationwide, the frequency of these tags is indeed increasing. And so up until this update, however, FTAG 605 was usually cited at a scope D or E with an average severity level of 2. But now, because of the migration of F758 into F605, the risk of higher scope and higher severity is very real. You're focusing now on the chemical restraint patterns of the utilization of these medications, and thereby putting the patient at potential harm. So now FTAG 605 legitimately becomes a high harm tag, and compared to what was on the national average at a lower severity level, the scope and severity is estimated to escalate as a result of the migration of F758 to F605. I'm going to pause there for a moment. Monica, Jenny, do you have any input or other additional insight on these specific points about FTAG 605?
I do have one point on that that you mentioned, Sandeep, on that average severity. The movement, while the severity can go up, just a reminder that because this is now a 600 level, this is an abuse tag. So even at a D level, and I think that there's a real risk in people, just kind of brushing off a D level tag, thinking it's not, there's no fines associated with it. It's not that big of a deal. When you are 600 level tag, you are by definition an abuse tag. And so you will get a red flag on the CMS Compare website. And we all know that will affect your ability to take patients in. It will affect your ability to, it'll affect your star rating. So even at a D level, even if you do not have an increase in the severity of it, you can see more D levels. And again, because it is an abuse tag, there is going to be an effect on your star rating and your compare.
Thank you, Monica, for that extra insight. You're right. I think when people look at A, B, C, and D, it's not really coming to necessarily the front of mind on the severity capability, and harming resident rights, and the use of chemical restraints, and putting psychotropic medication in that vein really changes the lens on this from a surveyor perspective. So thank you for adding that in.
I'll add one thing too. I think if you go back a slide there, thanks, Dr. Patel. The two points about informed consent and firm documented diagnoses. This is a common nuanced question that we get a lot from the psychiatry and the psychotherapy team. If you have somebody who has cognitive impairment, their ability to do an informed consent is sometimes really tricky and nuanced. And then the second one about firm documented diagnoses in the face of limited information, sometimes that's also very tricky. So I won't go into the weeds. Maybe people will have some thoughts or things they could put in the Q&A, but those are two that we get called in on a lot where it gets a little bit tricky.
Absolutely. Thank you, Dr. Byrne, for adding that in there. I think it just speaks to the need for communication and collaboration across the board, especially to avoid these sort of pitfalls that do occur. And quite honestly, I want this to be taken in the vein of not everyone necessarily has all the answers a lot of times. So if there are concerns or some form of even disagreement or misalignment on what a diagnosis could be for a specific medication, I think that's a great moment to collaborate and communicate with all team members involved and arrive at a final conclusion among consensus. So thank you for putting that out there. I put this up there, as many of you probably know. There's, for every major survey tag, there's always a critical element pathway involved with that, really kind of giving you the blueprint of questions that would be asked. And the thing about FTAG 605 and the use of chemical restraints, every single person, as you see here on that care team, is involved, from patients themselves to family members, from simple observations that a surveyor would make to CNAs, nurses, DONs, pharmacists, medical directors, attendings, so on and so on. I just put this up here not to go through every question, but rather simply to say, if it's in red, and this is from the survey manual, this is all new. And so the sheer number of questions that could be asked and or addressed during a survey process for this specific FTAG has grown exponentially. And it's great to be familiar with the types of questions that you'll be asked so that you're not caught off guard, but more so that it informs our ability to stay ready, not just for survey, but asking ourselves these questions in the capacity of, in the vein of answering, are we doing right by the patients that we're serving? And with that, I'm going to go ahead and segue into some additional commentary by our Vice President of Pharmacy Services, Monica Leriger. And Monica, you have an outstanding background, and people know what a PharmD is, what an MBA is, but can you kind of expand on BCGP and why that really matters to what we can help bring to the table for our facility partners here?
Yeah, so thanks, Sandy. BCGP stands for Board Certified Geriatric Pharmacist. So it's an additional level of training, education, and then test taking in order to achieve that certification in geriatrics. So it just naturally comes with your passion to do the right thing in this patient population. So I wanted to take a quick little step back and talk about the why behind this. Why are we so concerned about this? And just trying to break it down for all of my non-clinicians out there. There is something to be said for this particular drive for decreasing or removing a lot of these medications in our elderly population when we feel like they're the ones who are having these episodes and might need the medication more. But what we need to understand is that the body does change with time, which seems like an obvious statement. But I think we lose track of that when we start talking about the aging process. So what in a young adult could be considered a perfectly fine therapeutic dose can become toxic in an older body, even at that same dose, because quickly what happens when we take a medication is the drug has to get absorbed. It has to distribute throughout the body, and then it gets metabolized in the liver, and then it's eliminated through the kidneys. So as we age, every single one of those processes slows down, it changes as our bodies change. And a big one that I like to point out to people is that the metabolism, the effects of our liver are reduced by about 30% once we hit the age of 70. So that means there's 30% more of a drug in an elderly person's body with every single dose. And if we multiply that 30% by 15 drugs that a patient is taking, we can see very easily how we can take that simple low dose and it can lead to toxicity and all of that additional medication in the body, that polypharmacy leads to an increase in mortality. So this is why we really pay attention to these medications in our patient population, because we might be medicating somebody for a simple drug side effect of a blood pressure medication that might be causing them to have hallucinations. And now we have added another medication when what we needed to do in reality was actually take a different medication away. So next slide, please. Maybe someone change the slide.
I had the slide changed. Can you not see that?
Ta-da! There it is. Fantastic. All right, so there are a couple of uncomfortable truths that we really need to address here. So again, there are 4 parts that happen to what we call pharmacokinetics, right? Absorption, distribution, metabolism, and excretion. And the problem is that when we look at these 4, we can only account for one of them through any sort of a number, and that is, the elimination in the kidneys. We know we can get a GFR and we can calculate what that dose is supposed to be. Fantastic. But we've really missed out on those other 3 key components of that drug kinetics. So again, we really don't know what's going to happen when we add a drug to a system that is 30% less metabolized and we add other medications. We can't even just say, well, you're going to have 30% more of this drug, because that might be competing with another drug, and you might actually have toxicity in one drug over another. And this is why medication is an art, and why we have to evaluate every single patient for toxicities. And even before we start any new medication, we have to make sure that we're assessing for the signs, we're adjusting the medications that we already have on before we add something else. And once another medication is added, it's vital that we adjust those medications accordingly based on the patient's reactions. So that's why we're looking at what we call a GDR, or a drug gradual dose reduction. And just so you know, off to the side there are common signs of drug toxicity: dry mouth, constipation, upset stomach, nausea, flushed skin, about decrease in mobility, confusion, disorientation and slurred speech, hand tremors and headaches, agitation, anxiety, and delirium. Sure, off the top of your head, you could probably think of 10 of your residents that fit those signs of drug toxicity. So again, it's very common signs, and it can very easily be confused with medication or with a non-medication or just disease state signs and symptoms. So it's vital that as we're taking care of our elderly patients, we're reviewing each of these medications, and we're really looking at the efficacy and the necessity of each of these medications to improve those outcomes, but also to reduce mortality.
Thank you for that, Monica. I experience of and even for those that are not clinicians on call, I think it would be extremely beneficial for us to take away some of this basic knowledge of what drugs do to the elderly. FTAGs were born out of a need to protect elderly against the effects of adverse reactions to medications. And so this one specifically is really looking to target a specific group of medication that, when used in excess and inappropriately, can result in some harm. So I think it would behoove all of us to make sure that we have the basic tenets of what drugs do to elderly, take that back to our teams, educate our teams on those basic effects, because more eyes on the situation definitely helps us as clinicians help make better decisions in tandem with all of you. I'd like to now go ahead and introduce Dr. Jenny Byrne, our Associate Chief Medical Officer of Behavioral Health. Dr. Byrne, would you like to take it away for us?
Yeah, sure. Welcome to everybody. I hope we have a lot of non-clinicians on the call because you all are really out there on the front lines, and we know just how hard that can be, especially if you have to work with clinicians on the team. I know you have families, you have patients, you have your staff. So I know it's a really tough job to kind of balance everything. So I'm going to give a point of view that's a little bit kind of like, let's get real about like what we're talking about here, because I could give you a very high level conversation about psychiatric disorders, et cetera, et cetera. But the reality is you all need practical tools that you can use day to day. So hopefully that's what I'm going to share with you here today. Okay, go ahead. So this is the reality I'm imagining of what many of you experience every day. You are caught in the middle of trying to do the best job you can, and you're trying to find that sweet spot in the middle of that Venn diagram. So you're trying to do things that are right for the patient, right for the person in the building. You're trying to do things that are right for your building, for your facility, and you're trying to do things that are compliant and right for CMS, which is trying to understand population health. Now, I could have put another circle in there for the family. I could have put another circle in there for different team members, but just to keep it simple, let's just say that you have three groups of priorities, and sometimes they don't match up. So I want to just call it out and like, let's be real. Sometimes these priorities conflict with one another and you're stuck in a very difficult situation. As a psychiatrist, I am currently the one that sits right in the middle, and I often get called in when things are a little bit tricky, which they often are. So I wanted to give you a couple concepts here just to think about this problem and how you can get away from language like chemical restraints. I'm not sure how they chose that language. I think that's very aggressive. It almost makes me think of prison, and that our patients are like chained to their beds like prisoners. It's a very aggressive language that they have chosen, and I understand that it's meant to be protective. But the reality is, I'm going to start actually over on the right of the screen here, that probably if you take away nothing else from what I say, I'd like you to take this away. We are trying to provide our patients with comfort, not sedation. So I think when people say chemical restraint, what they're really trying to say is sedation. And if any of you are up in the Northeast, up in the New York area, you would say, don't slog your patient, right? A slogged patient is the one that's knocked out with a bunch of meds, drooling, sleeping all day long. Like, let's get real. That's what we're talking about. We don't want patients that are toxic, knocked out, drooling on their beds. That is not comfort. Okay, that is sedation. So what we're trying to do is thread the needle on how to make them comfortable without over sedating them. And that is not always easy. So I think that's the key concept here when you're talking with your teams, is we want patients to be comfortable. We don't want them to be sleeping all day or risk of falling. So how do we do that? What are some other concepts that you and your team can use? And I'd love if people have thoughts to put them in the Q&A. I can answer them live, or I can chat with you, or we can answer them offline. So some of the ways that we get there, and again, this is where as a psychiatrist, my team gets called in pretty frequently, using the entire care team. So in trying to understand what comfort means and what the different medicines are, you have typically a team of people there to think with you. So if you're working with Eventus, for example, you already have 3 different team members right here. You have Dr. Patel, who is from the primary care point of view. You have Monica, who's here from the pharmacy point of view, and you have me from the behavioral health point of view. I bet you have other people on your care team, the people that are on the front line, sometimes even the people, the administrative staff in the building has information about that patient. Are they looking uncomfortable or agitated a certain time of day? Maybe they're only agitated at 3 p.m. and the rest of the day they're totally fine. So they don't need to have medication on board all day long. Maybe they only need it 2 hours a day. Maybe you've noticed that they're looking very uncomfortable even though they're not saying anything. Maybe there's body language to pick up on. You don't have to always be a clinician to have this information. So when you're getting information about the patient, using the entire team, it's really a time to do that. And if you have some sort of interdisciplinary team rounds in the building, if you have a physician that rounds at a certain time, using those opportunities to go through and get everybody's perspective, sometimes we'll find solutions in unexpected places. I've had many times where the clinicians, like, again, to be real, had no idea what was going on. And it was literally like the cleaning staff who had the best information on what that patient was experiencing because they saw the patient all day long. So I'm not saying that's the case for you, but try to get everyone's point of view. The second concept, I think, which all of us are guilty of, myself included, is under communicating. We all tend to be very heads down and just stay in our lane and do our thing and just kind of focus on what we're doing in that moment. And it does take extra time and effort to communicate what we're doing with others. So, many years ago when I was in the field in the buildings, I actually figured out a workflow where I could call the family of every patient I saw that day. Now, I'm not saying that's realistic all the time today, but I tried to really over communicate, and I found that a 5-minute phone call went a really long way in taking care of these complicated patients. If I could talk to a family member, sometimes I'd get more information. Sometimes I would just reassure them. And that would go a long way. So kind of over communicating with your team and with people outside the team. It does take more time and effort. I'm not going to lie to you, but sometimes those tiny little 2-minute conversations really matter. Moving over to the left, another key points which sometimes I see people miss is the cadence of monitoring. A lot of clinicians get into kind of habits of monitoring where they'll say, I'll see you every 2 weeks. I'll see you every 4 weeks. Some psychiatrists, I'm sure come every 3 months. Managing these complicated patients who need comfort with psychiatric medications, every 3 months just isn't going to cut it. While they're titrating, adjusting, deprescribing, changing meds, the cadence of monitoring often needs to be very, very frequent. It may be once a week. I've had patients, sometimes it's once every 3 days. I need to check in with somebody. It doesn't have to be a visit. It might be a phone call or something else. So kind of getting out of the mindset of well, this doctor comes at this cadence, so that's how often we're going to change the meds. Well, just because the doctor comes every month, that doesn't mean you should wait for the next month before you make a med change. So sometimes I see we get a little bit stuck in our heads on that one. The other one, and the language I like to use for taking people off medications, is deep prescribing. And I'll say that, many psychiatrists, I think if you're doing a good job as a psychiatrist, at least 50% of your job is taking people off medications. And coming up with a plan to do that really helps the team and the family and the patient know what to expect. So for example, instead of just saying, I'm going to, let's say you're on, I don't know, olanzapine, Zyprexa. Let's say you're on 10 milligrams. Instead of just saying, I want you to go down to 5 milligrams, I'll see you later. I would actually write out my plan. Here's my tapering plan. First, we're going to go down to 5 milligrams. If we don't see any problems in the next 7 days, I'm going to go ahead down to, 2.5 milligrams. I'm going to watch 2 weeks, and then I'm going to go off. And then I would also have in my plan, when we go down to 5, if you see these behaviors emerge, you were going to do whatever. You're going to call me, you're going to send me a message, you're going to talk to the primary care doc, whatever I want you to do, So at each step of the de-prescribing, there's a plan. It's not just like decrease the dose. It's not stop the med. It's make this change. And then if you see this thing happen, I want you to do that next. So clinicians are sometimes guilty of just trying to go quickly and they may not write out a plan. I do think it's very reasonable to ask your clinicians to write out the plan for the de-prescribing rather than just saying decrease this med. So that's a thought in terms of helping you with that communication piece. If you're not on the phone with each other frequently, at least maybe in that written plan, you can say what you're going to do to taper off a med. And then my final thought for you all is like, be flexible. Like this is really hard work. There's not a good FDA approved pathway to treat these behaviors, especially in patients with dementia. If you go look at the FDA, there's not a lot of meds that are FDA approved for treating these problems. So, again, as a psychiatrist, I always tell people, like, when it comes to treating these behaviors in the elderly, there's maybe like 10% science and 90% art. And sometimes medicine and health is an art, and you got to get flexible. Sometimes that means using weird doses, cutting a pill into halves or quarters. Sometimes it means giving a med at an unusual time of day, which I know for building staff can be really hard if you're trying to figure out your staffing for handing out meds and the patient needs the med at an off time of day. That's really hard for you guys. Be flexible with like what meds are used. Sometimes I'll use meds as a psychiatrist that others don't use, like buspirone in small doses I might use, or some other meds that just aren't real common, but are pretty benign and have fewer side effects. So just being flexible and trying to think a little bit outside of the box in this population where we're at right now with the science, like honestly, it's mostly art. And so you kind of have to be a little more creative in your thinking sometimes. So those are just a couple ideas I have for you all in terms of concepts to help you think about it. Again, if you have any questions, please put them in the Q&A, or we can certainly get in touch with you after today's presentation. But it's real hard work that you all are doing. I appreciate everything that you do every day. And you have a team of people to help you. So I hope that, maybe we can answer some of your questions today. Thanks.
Fantastic. Thank you, Dr. Byrne. And, adding to this diagram, I love how everything that we do centers on what is right for the patient. And I love how that circles right up top there. I think the thing to come away with is what is right for the patient is not just the drug at the correct time in the correct setting for the correct reasons, but also making sure the rationale for that correctness is documented appropriately, because then that becomes right for the facility and right for CMS. And it may very well be where, from the medical director lens, I encounter this concern all the time. Dr. Patel, we got to get our psychotropic rate down. Great, wonderful, broad question. Let's talk reality, though, as to what is right for each specific patient. And it may very well be justification is there, it's necessary, but our documentation is the key to avoid the survey traps that many times we're all trying to work towards avoiding, and at times working too hard to avoid survey traps and then losing sight of what really matters, which is what was truly right for the patient at that time, and do we have that firm checklist in place of making sure everything is in place to justify continued use. And at the end of it all, been doing this for about 17 years now. I can tell you documentation wins each and every time. And so as long as everything is justified through the documentation means, both the surveyors and hopefully you as our facility partners are happy with the results that are put out there. So Dr. Byrne, thank you for sharing this. Really appreciate it. So Monica, I see that your hand is up. Would you like to add something to that, please?
Oh, I just wanted to really comment on Dr. Byrne's addition of be flexible. I think that's really spot on. And I think that's something we lose when we know these patients so well. We know these patients. They've been in the building for years. And we've known that we've used these medications. We've needed these medications. We've documented the use for these medications. But the patients had a changing condition. And now everything that we've had, we need to reevaluate. Because there's been a changing condition. It's really hard to be flexible when you know this patient so well, understanding that there is a change and now everything's got to be reviewed through a new lens now, this new changing condition lens. It's really hard when you put so much effort into caring for somebody to have that flexibility. And I just think she really nailed it there, that we really need to make sure we're taking that into account. If a patient comes back after a stroke, we need to reevaluate those medications that increase the risk of a stroke. Even though it's going to be difficult and it's not going to be a pretty conversation to have with the family, it's something that we really need to have.
Fantastic point. I think it's important now more than ever, especially in light of trying to balance these three very rings that you see here. So thank you for putting that through, Monica. So heading into some potential solutions, and once again, when we look at solutions, these are very, quite honestly, when we go back and reflect on them as leaders of our respective facilities and clinical teams, they're rather common sense. Ensure that your staff knows the why behind for the intention behind it is really to protect patients. So the more we understand our patients, i.e. through, say, understanding the aging process, what Monica had showed in the very beginning, up to and including why certain medications may be justified in some patients and not others, really informs our ability to succeed with FTAG 605 navigation. I say this specifically because, as you saw in the very first slide, they're looking for in these medications. What is being deemed a chemical restraint? And one common thing that comes up is sleep cycles and sleep schedules. If the patient has midday naps and midday habits that are usual and baseline for them, document that in the care plan so that when a surveyor does come around and see that the patient is kind of asleep and whatnot at 1 p.m., it's not because they're sedated despite being on Zyprexa, it's because that's their normal self. Just be very diligent about documenting that pattern, or documenting any pattern for that matter. Make sure non-pharmacological interventions are in place and utilized, and have back checks to make sure indeed that these are indeed being implemented. Document the informed consent discussions, not necessarily through a piece of paper, but that an informed discussion took place with the responsible party, utilizing the drug, the indication, the risks and benefits of it, and of course, any non-pharmacological interventions that were tried and failed. Once again, coming back to excessive sedation and withdrawal, social isolation, maybe weight loss as a result of using some of these medications, document what their usual meal intake pattern and habits are. And therefore, when surveyors come by and say, oh, they're only logging 25% of intake, could that be the antipsychotic or antidepressant that they're on? Maybe, maybe not, because this is their baseline pattern and habit. So make sure that's documented in the care plan. What is their usual socialization habits? We have a lot of introverts in our facilities, and they wish to keep to themselves. Just because they're in the room and tell the surveyor, I don't want to do art, I never want to do art, that's not because of the meds that they're on necessarily. Could be, but not necessarily. But if that's their usual habit, once again, let's get that down on paper so that we know what their baseline pattern is, not misconstrued as an adverse effect. Now more than ever, ask yourself if your consulting pharmacist is engaged in making GDR recommendations and rendering follow-through. Quite honestly, the consultant pharmacist is the secret sauce. It's very easy to go to your medical director, your attending physician, your behavioral health team, but that pharmacist needs to be an integrated part into that decision-making for that patient. And then communicate changes. As you saw on the last slide, over-communication in any changes in mentation, sensorium, intake, activity levels, and whatnot. Please communicate those promptly. Never take that as necessarily, oh, it's going to be a one-off and nothing. Follow the chain of command in your facilities. Reinforce and empower your CNAs at the base level of ADL support for your patients to empower them to report any abnormal findings. It shouldn't just be all on nurses themselves. Our CNAs need to be involved in this. And finally, you saw earlier, did we mention QAPI? Make your QAPI meetings very intentional about asking some of those questions so that everyone all around is protected, the patient and the facility. And what that all have play. FTAG 605 navigation is just not a medical director thing. not just a primary care thing, not just a behavioral health thing, not just a facility thing, but all of us bring a piece of this puzzle to the table to solve. So I would like to just end on that note from our standpoint here is we're here to continue our partnership with you. And what we're really looking forward to right now is a dialogue on seeing how we can continue to improve that partnership and or create further solutions for you to help you navigate FTAG 605 more successfully. So with that, I'll go ahead and open up to the floor and or the chat if there's anything out there that we can help with. And please don't be shy. This is a forum where we want these thoughts to come through so we can help inform better solutions for your facilities.
So Sandeep, there was one question on whether this was for all psychotropics and not just antipsychotics. And
oh yeah.
Yeah, that is absolutely true. This is, and I'll take it a step further. So it is for all psychoactive medications. So some things that were not previously considered psychotropic medications, hydroxyzine for anxiety. If you state that you are using it for a psych purpose, it becomes a psych medication in the eyes of a 605 possible chemical restraint. So that is a great question. Yes, this is for all centrally acting medications.
You're correct. And, the focus while on the psychiatric medication, yes, it really hones in on anything that acts on the brain. And that could be both psychiatric and non-psychiatric medication. Yes, it is a rather broad tag with the focus really centering on the psych meds themselves, but keeping in mind that all patients should be free of any excessive dosing and or improper medications that affect brain function. Well, we still have 15 minutes, so if you have any commentary, we would love to hear your experiences with FTAG 605, what surveyors have been saying at your facilities, maybe some challenges you've encountered in ensuring adequate documentation or even engagement from stakeholders, whether it be from internal within your facilities, from medical directors, attendings, nurse practitioners, PAs, behavioral health teams. Please, by all means, feel free to share.
I do have a couple of things that I can share from the recent data poll of 605s.
Go for it, Monica.
Questions. So, as Sandeep had mentioned, so far it looks like the 605 tags have mostly been across the board level D tags. There have been 82 F605 tags since April 28th, since this new one went into effect across the United States. The majority of them are a D level tag. So 67 of them were a D level tag. There were 2 G level tags. So there were 2 harm tags, one in North Dakota and one in New York. I will say that all of the tags so far have been on surveys, annual surveys. They have not come from a complaint tag, which is unusual to me. I would have thought that there would be more complaint tags because of that. I'm sorry, for the D and E level. Those 2 G level tags, apologies. Those 2 G level tags both came from complaint surveys. So when we see that there is a complaint that comes in, they do tend to tag that higher. So again, bringing in that family, because we know that the families are the ones who are going to be calling. So the more we can make sure that the families are engaged, the less likely you're going to get a harm level tag. But understanding that each one of these tags did flag each of these buildings for abuse. So again, that is 81 tags, 81, 2 for the same. So 81 separate tags for abuse since April 28th of this year.
So the absolute numbers may seem relatively low. The trend is there on scope and severity from what I understand from that, Monica. Is that correct?
Oh, well, yeah, like I said, every single one of them becomes a tag, but I mean, understanding that that is a huge increase in the 605 tags. And again, that is only since April. So And that actually pulls from April 28th until July 16th of this year. So that is 81 tags in only 3 months' time. That to me is a significant number of tags. Because if we extrapolate that out in just 1 quarter, you're looking at over 320 tags, which far exceeds what we've had for that in previous years.
Thank you, Monica. So once again, we are here and available for you should you have questions, concerns, commentary, or even a story to share with regards to your experience with this specific F-tag. Please feel free to reach out to us at any point should you need. Michelle, I don't know if it's possible, but if you could please maybe enter our email addresses into the chat, that'd be helpful. Otherwise, if there are no further questions or any other concerns anyone wishes to share, we bid you all a wonderful afternoon. Thank you for a little bit of time that you've shared with us today, and we hope to engage with you soon.